you have a question, please raise your hand so that we know, and then Zach will unmute you so you can take your question. All right. So why did we do this upside study? It's about peer support. Peer support is the idea of people with lived experience of mental health crisis and recovery. These are the peers. There's support others on their recovery journey. There's accumulating evidence that peer support is effective, but there are evidence gaps, especially in low middle income countries and in non-Anglophone high income countries. Next one. So we did the upside study. It was a 8-site study. 6 sites were recruiting sites. Non-recruiting sites were Nottingham and London, and recruiting sites were in 2 sites in Africa. There was Tanzania, Dar es Salaam. Donat is here to talk about this a bit in his presentation. And there was Butabika National Referral Hospital in Kampala, Uganda. Then there were 2 sites in Asia. Was Israel. Galia is here. We'll listen to her talk later. And in Pune, Gujarat, there was Jasmine Kala, who was leading there. No, wait, I wasn't done. and then there was Hamburg, Candelaria is here, and myself. And yeah, done now. Next one. Sorry about that. All right. Main goals of the study were to analyze the current state of peer support, developing a peer support program, scale up the peer support where there are already initiatives, or introducing new programs of peer support at the study sites, and then to evaluate the effectiveness of peer support and sustainability, implementability. So you will hear a lot about this today. Candelaria Mahlke will start with a training talk. Then Donat will talk about experiences in Dar es Salaam, and a qualitative study. Galia will then also present a qualitative study on the experiences of peer support workers, and in the end, I will talk about the RCT that we conducted and present the results. So welcome again, everyone. And now I would give the floor over to Candelaria to present about developing a training on peer support for people with severe mental health conditions in diverse settings.
Okay. Can you hear me?
Yes.
Yes. Okay. Yeah. Thank you so much. My name is Candelaria Mahlke. I'm from Hamburg, from Research Group for Participatory and Collaborative Research. That means that we do all our research together with peers or service user researchers or panels with people with lived experience and carers. So this is the Upsides network with our peer support workers as well, who are the main characters in the study, who really shaped the peer support work, the training, and the intervention. So thank you to everyone who joined Upsides and helped us here. Okay, so first, the developmental process of the peer support training concept. So we had different systematic literature reviews to have the evidence base for our training. So one on peer support worker trainings, one on influences on the implementation of peer interventions, and one systematic literature research review on intervention modifications. So that was one base for our training. Then we looked at site-specific training concepts because we wanted to see what's already there in the countries, what peer support trainings do they have. There is the Brain Gain program in Uganda, who was a really, really big influence to our training, as well as the IMROC training in UK. Julie Repper in Blue Mills developed the training with our Hamburg location. So they had a big influence as well. In Germany, we have the Ex-In curriculum. It's a German-wide training, and it's also in Austria and Switzerland. in India, we had the quality rights program that you know for sure. That's adapted for many, many countries. In Tanzania, there was the Healthy Options program that was for postnatal care. Then the P2P training from the UK and the Josma Direch Halef, I don't know if I said it right, training from Israel. So we looked at all these trainings and took some elements that was fitting into our overall training program from each training and made some focus groups. So we developed a core training with 5 elements. We did a focus group evaluation on the first training concept to see what peer support workers and mental health staff from each side were saying about our training. Then we did an expert consultation after conducting a train the trainer workshop. And then we did focus group evaluation of the pilot phase training and intervention. And then after adapting the training, a last round of focus groups for the field version that we have now. This is the Train the Trainer workshop in Tanzania in 2019. One of my dearest memories, I have to say. It was a 5-day workshop that was held in Dar es Salaam. Thank you so much to Donat and the team who invited us and had us there. And at the Ifakara, or from the Ifakara Health Institute. So from each country, one trainer tandem joined us. So one mental health staff and one peer support worker or peer support worker to be. So we always had a tandem that could train together from some sites. For example, from Tanzania, there were more than one peer support workers there. Yes, we have a little bit more on the website. There's a website from Upsize as well, where you can see some pictures and newsletter and everything around the Upsize program. Okay, so what is the Upsize peer support intervention? It's, of course, peer support people who are having experienced mental health problems and recovery, that they use their personal experience along with the Upsize training and supervision to facilitate and support another person's recovery journey. So there are some specific tasks that we shaped, like recovery planning, practical support with daily life, linking and mediating into services and the community, and promoting recovery orientation in mental health teams. And it was mainly around one-to-one peer support, but we providing an additional recovery group setting was possible and recommended to support the network aspect from peer support as well. And for example, in Israel, you focused on the group setting. Okay, so we did the first focus group evaluation of the pilot phase. In the pilot phase, it was 6 weeks and took place at all the recruiting sites. There were peer support workers, 22 for the 5 sites. They were working with service users. So after this pilot phase of 6 weeks, we presented the training concept and the resulting peer support intervention and asked questions around the acceptability and what was missing. As this was not only on the training, but also on the intervention and the first piloting of implementing the Upsize peer support at the sites, we have a really broad interview guidelines. But the main feedback was very, very positive about the benefits of the training, but there was a need for more role plays, for more practical exercises and less theory. So the first training, we organized a lot around the principles of peer support work and also on theoretical discussions about all the principles. And that was the learning from this pilot phase that we need a more practical solution here. So all these results can be found in our publications from the Upsize project. after this round of focus groups, we reshaped the training, and it resulted in 12 training modules. That was the core training. So we also manualized the first pilot training, but we manualized this as well. It has an accompanying workbook for the training participants. And the core training can be supplemented by additional modules. So we try to look at what do we need on every side to train peer support, but also have the possibility to add some topics that might be site-specific or might be more relevant at some locations. But of course, it's all around recovery. Then we used a lot of the tree of life. That is a concept that was used in Uganda in the peer training, and it really shaped our training. And when we talk about the training, or for example, we were in Sweden right now because they implemented upsides. This tree of life is like a really core element, and it's everybody loves it, I have to say. So for me, upsides and the tree of life are really connected. So it's about peer support. Of course, we have communication training, how to support recovery, how do you build on strength and build a community and perspectives for the service users. Then we have trialogue as an element. That means the communication between service users, carers, and mental health staff to talk about future steps, to talk about care and what is needed. Then really important to shape the role description for peer support workers. And we have a module on group facilitating, work preparation, and how to build a peer network. So the length and duration can be amended flexible to the setting, and that was really different from site to site what were wished for. In the manual, you have all the core elements that you should train, but how long you do your training, or if you do it all one day after another or stretched over some weeks, that is flexible. So we did a last round of focus groups for our training refinement. It's with 44 participants from all study sites. And we asked about acceptability and training modifications. So the applicability, for example, was, yes, rated very positive, but the main topic was enhancing applicability through better guidance, clarity of training program management. So one very important part was the selection criteria for participation on the training, then talk about employment conditions as well, and have the right resources for implementation, so that you should take a look at these aspects before you start the training. On the adaptation, it was again that adjustment should include more detailed and interactive learning content, so that you could really shape it to the local I'm sorry, to your location and what's needed there. So, for example, the duration of the training or interactive learning methods. So, common characteristics of the training, strengths and weaknesses were asked. So additional training should enable organizational system change. So that is also one part of training for the service users, to think about how can I guide system change, how can I participate in discussions well in the teams, in the institution where I'm working, and how can we support peer support workers to introduce system change. Then we asked for missing contents in the training concept, and again, it was really emphasized that we need a lot of role play and a lot of practical trainings. So communication is one really, really important part, but also how do I use my lived experience in the training, rights and advocacy, and this specifically for every location because it really depends on the system as well, how to take good care or self-care as a peer support worker and then to build on skills. Yeah, and one main topic for us was well the cultural differences. So mental health system priorities and social norms and social inequities really influence the training. So it's about perspectives on mental health in a location. So maybe you adapt your training program also to give them more education about mental health. Then how to provide community involvement, and of course social inequities that really shape peer support work and peer support training as well for our study sites. So after this, we took our training manual and our workbook and finalized it with the last focus group results. So now we have our training manual that you can download from the UpSites website, as well as the workbook and the implementation manual. So yeah, the final version of training is there to be adapted to locations all over, and we are very, very happy to give guidance, and we really hope that the UpSites training will be used further in the future. In 26, we had a co-production workshop with the Lund University in Sweden. They are having a multi-center LCT now on UpSites group interventions and want to implement the UpSites groups all over Sweden. And then I'm finished here. Thank you so much. If there are any questions.
Thank you, Candelaria. I said in the beginning we'll take questions at the very end of
Yes.
all 4 presentations, but you were nice and short. So if this is technically possible, Zach, we can take some questions now for Candelaria's presentation, maybe 5 minutes or so. I'll look in the chat if I can find anything.
Sure. Okay.
Yes, the manual is available on the UpSites website, and you can see the link. It's upsites.org right here, and then you can browse through. There's a section manuals, and there you can download it.
If you have
Actually, I was answering the question for you now, Candelaria. Sorry about that. It's your questions.
Okay.
Can people raise their hands now, or will that only be possible at the very end of the session?
So far, all of the hands are down.
Okay.
So I think we can just continue.
Okay. So wait a bit, and then we continue. All right. It was actually the second time
that you rushed through the presentation.
No, you didn't rush. You
I
didn't
hope
rush.
it
was very good the way it was. No, you didn't rush. It was very good the way it was. It was the second UpSites training now beyond the original study sites that you did, Candelaria. We had a one. It was last year, I think, in India also, where people, where the Indian peer support trainers trained at another site, UpSites peer support. And as you said, I would be very glad if this wonderful intervention would be spread out more.
Yes, we were also
many places.
Of course, I will just mention that we were also supposed to have another training and are planning to have another training in Israel.
Yeah.
Just to say, Candelaria, my gosh, so much work on this process. You remind me of the journey that has been done. I think just to say a word about the manual, that I think what's unique about it is that it's a very good, systematic, thorough buildup of a manual that is based both on the most contemporary literature on peer support and recovery, combined with bottom-up, people with lived experience, peer support workers' own inputs into it, and also, of course, multicultural because of the different sites. And I think it's a very unique product, this manual, which sort of brings peer support to its best in terms of both getting the principles that work best across all sites and still being very sensitive to the different local, cultural, organizational aspects. So thank you for reminding me. I was really appreciative of seeing this again and just your whole team doing this part of the work, which was the basis for this huge project.
Yeah, thank you so much, Galia. Yeah, as I said, in the end, it's really the peer support workers all over our study sites from the different countries who shaped this training. Yeah.
All right, I see no more chat chat news or raised hands, so I suggest we move on to the next presentation. That will be by Donat Shamba from Ifakara Health Institute in Dar es Salaam, Tanzania, who will present about societal and organizational influences on implementation of mental health peer support work in low income and high income settings, a qualitative focus group study. Thank you again for being here, Donat, and really looking forward to your presentation.
I can't hear Donut. I don't know if you can hear him.
No, I can't see him and I can't hear him. You're muted, Donat?
Sorry, apologies. I was
Yes. Now.
didn't realize that I was on mute. Thank you very much. Oops. Yeah, thank you very much, Ben. And first of all, I would like to express my sincere gratitude for the collaboration that we had. There was a lot of lessons that we learned here in personally, but as a country through this consortium. It was a great opportunity to collaborate, and I hope there will be another one in the future. So yes, I will present societal and organization inferences on implementation of mental health peer support work in low and high income settings. And this was part of the analysis of current state of peer support work. I also want to acknowledge that this work was led by Ifakara in collaboration with University of Nottingham and from University of Nottingham was led by Professor Mike Slade and Ashley Charles. And my colleague Mary Ramesh, who is not able to join this webinar today. So global mental health treatment gap remains largely challenging, especially in low resource settings, leaving many individuals without necessary care. And this is the reason why peer support worker can offer a solution by leveraging lived experience and mutual recovery to address unmet needs and promote well-being. Most evidence on peer support workers come from Anglophone high resource settings and limited in lower and middle-income countries and also Anglophone high-income countries. So by acknowledging these gaps, we think it's high time to influence peer support implementation across different settings and also at different level of healthcare systems. As I said, this was part of understanding what is on the ground, and then we aimed to explore the characteristics and the societal organization influences on the implementation of mental health peer support in low and high income settings, and was part of the upside study as was introduced by Candelaria earlier, and Ben, sorry. And so we did a qualitative study guided by critical realist and involved focus group discussion. And the participants were mainly the peer support workers mental health clinician and the managers. We also involved policymakers. A total of 12 FGD were conducted. So where this study was conducted or were done, so this was include 5 upside study settings, Europe, Middle East, and Sub-Saharan Africa, and also high-income settings in Germany, and these were Hamburg and Ulm and Israel, and then low-income countries including Dar es Salaam, Tanzania, and Uganda. So this analysis was done using thematic approach, and the validation was done involving different or multiple researchers. And there was weekly consultation just to ensure that there was a consensus what was found from the data and what was reported. And that was supported by the NVivo software. So what did we find? So we came up with about 6 themes, including community and staff attitude, peer support networks, resource availability, training and support, role definition, organizational culture. So starting like community and staff attitude, looking at the stigma, discrimination, and acceptance were things that emerged mostly, and specifically in low resource settings. And some factors appear in both settings, but others were differed, but intensity in expression, and those, of course, late based on the culture and experiences, because some of the settings had prior had experience using peer support workers, and others were not, like Tanzania. So having network and increase access to peer support networks and enable them to address potential challenges and feel comfortable and strong. But where there was a need of resources, for specifically on financial and infrastructure constraints, limited to reach and quality, and this including holding meetings or accessing care and even groups, and training and support. So also reducing uncertainties among professionals and ensuring a sustainability of the workforce. And this is, we just heard from Candelaria specifically, and also Galia recommending the training manual was very, very useful later on, but this was before that was developed. And then organizational culture realized that some settings, those are rigid hierarchies and was hard to penetrate, but there is a need to engage key stakeholders, ensure to make sure that that change and especially the managers or policymakers understand and support the system and the governance to change to accommodate the peer support workers. And role and definition. So as I said, some settings had experience using peer support workers while others didn't. And at some settings, the health workers were a little bit uncertain whether there would be attention on specific on the role, what would a peer support worker do, and what would and nurses, psychiatric nurses do. So having like a training manual with a clear roles and responsibility that could be avoided. So just a few illustrative quotes here that some were very negative. For example, the first one from Uganda, that some felt like if using peer support workers who experienced or went through mental illnesses, how can you continue to work with somebody like that? And this also, as I said earlier, linked it to cultural differences in some, and also stigma as well. And then policymakers, for example, from or mental health clinician in high income countries like Israel reported that current policy needs to change. The policy says peer specialists have to be everywhere, and it requires resource which we don't have. What we need to get a special budget to support. So finance and as resource was critical. Sorry. Yes. So what are the key things that we can discuss is that peer support work implementation, we realize it is mainly shaped by societal attitude and organizational culture. And then training and support system must be context specific and based on experience and culture and stigma and resources. So resources both financial, but also having available human resource for health enough and skilled to support the structure and the system and the intervention as well. And also integration require anti-stigma effort, organization flexibility and sustainable funding. What does it mean to the global health, mental health? For policy, it's important to integrate peer international mental health strategies to formalize and support workers in scaling up contribution. And in practice, it's important to foster recovery-oriented organizational culture that value lived experience and promote peer support. And for researchers, there is still need to explore more links between stigma, resources, and implementation outcomes to build an evidence base of effective peer support work models. Yeah, I will just want to leave with the take-home message: the peer support bridge gap between users and the providers and promoting empowerment, sustainability, and inclusivity. With mental health systems, peer support work is valuable component in moving towards more holistic and person-centered. So what I've presented was part of the publication that this paper was published in BMJ. So you can find it, you can Google it and you can find it, and please feel free to read. Thank you very much. I think this is my last slide, yeah. Acknowledging the support, of course, from the European Union, the grant, the local teams in all countries that the data were collected that contributed to this particular work, and the peer support themselves. Thank you.
Thank you very much, Donat, for this wonderful presentation. I think it shows very nicely how peer support worked in practice, and you get a bit of at least that's how it felt to me. You get a bit of an idea how then it really happened. So yeah, thank you very much for this, and it was also nice and short. So again, if there are questions or comment, if there are questions, please raise your hand or use the chat. Yeah, there was only a very nice comment praising you. Don't I just thought it because I saw you on video before. You don't have to put on your video, but if for some technical reason it's not. Oh yeah, there you are. Okay. I missed you. Thank you for that.
Well, I
And
was putting the video off for restoring the bandwidth of the internet
all
connection.
right, all right, all right.
Yeah.
So yeah, there was Claudia Sutter saying that was very insightful. So that's not a question, but thank you very much, Claudia. I think so too. And Tina, what the name is cut off. Tina Walter. Thank you so much for the presentations and the great work you did. One question to all presenters: how did you perceive and negotiate potential power hierarchies between the different research sites? So I think it would be as you presented, Donat, would you like to say something about this?
Well, I don't think there was or whether we felt hierarchies between uh, uh, different research sites because we work as a team. We had meetings to design the data collection tools because we had our objectives and the divided work packages. And as I said, the work package two, which was part of the analysis of the current state, like a situation analysis, was led in collaboration between Ifakara and the University of Nottingham. And then we brought and the others, all other research sites or other partners sent a representative to when we were developing the plan for conducting this particular research, including the developing the guide and also conducting research. So we didn't travel to Germany to collect data, rather than the teams in Germany collected the qualitative style collected data, the same for Israel and the same for India. Uganda and Tanzania. So our team collected, and once we had the data, we discussed, and when we needed some clarification on or interpretation of the findings, we had those meetings to discuss until we were comfortable. And then Mary and Ashley started writing up the paper that I showed you at the end. Ben, add if there's anything I missed, but I think those.
No, thanks.
And this is one I would say maybe for equity, or we talk about global health, the decolonizing global health. So, which came later actually, but after when we were implementing this study, but before that notion didn't come very clearly. But I liked very much this collaboration because there was a mutual respect for different partner, whether you are in a low resource setting, like or low income setting, or your high income setting, but there was an equity of dividing roles for each partner, and each partner in the consortium had equal value. That's how we felt it, Ben. And then maybe I didn't say this to you, but I'm saying it today. Yeah. So yeah, for example, the main paper, I'm the senior co-author, and then something that in the past we wouldn't say that all the scientists from the north will put themselves first author and senior author, and you will be muddled in the middle. But this was not the case. Thank you very much. Yeah.
Can I also add a word to that from my perspective?
Yes, please.
I agree with Donut, and I'm trying to think now of this important question in hindsight. What made it feel such a great collaboration with a sense of warmness and mutual respect and a learning? I think there was a huge learning on side of all researchers, peer support workers, professionals who got together and worked together. And I think it speaks to two or three things. One, again, I also have to hand it in to Professor Bernd Puschner for excellent organization and making sure that everybody takes part with these work packages and working very systematically and really making sure that nobody is left out and everybody can have a meaningful piece of the cake, as they say. In papers, in the implementation, in the local sites, there was always a piece in there. And I also think that another thing, speaking of resource-wise, I think that Bernd made sure that the very big meetings were taking place in Uganda and Tanzania, so it would be easier. Everybody came to Africa instead of usually traveling the other way around, which allowed for more people in those sites to join also from the local sites that would not be able to come to Europe. And I think that was very impactful, and also, again, a very impactful and meaningful learning experience for us coming from other places. And I had one more point, which now slipped my mind. So Candelaria.
Thank you. I think one aspect is as well, if you work as mental health staff, for example, with the topic of peer support, you already have to be really, really humble with what you are coming, where you are coming from. So I just have the academics, but the people I'm working with, they have the lived experience, and it's the most important. Um, it's the core for mental health, I think, for peer support programs. So there already is this aspect of changing perspective if you are in the field of peer support work, I think. And I think this made it also easier. So you try to get all on eye level, doesn't matter where you come from, what experience you have, if it's academic, if it's lived experience, and get an understanding from everybody in the room. And I think that really helped. And I'm so, so grateful for everything I've learned in this project. I'm really grateful to Bernd, but especially to Donald, who hosted us in Tanzania. It was so great to get to know everybody and how they work, and how peer support can be useful at all these sites. So yeah, thank you so much. And I think there was one question about participation and co-production. For example, at our study site, we do everything with service users. So all our interview guidelines, for example, are reflected with a panel of service users and carers. So developing the training program was together with peer support workers and people with lived experience. It was commented also by carers. So I think we really tried to find a good involvement strategy here in UpSites. Yeah.
Just to add, yeah, you've been saying very nice things, and yeah, so I will not comment on the power balance question more. If this has been hopefully adequately answered. Sorry, I don't see the names of the I only see L. No, that was by TM. So yeah, just to add to the question by LM, there were local advisory boards at all study sites, which were vital in contextualizing the implementation. There were service users, carers, mental health professionals, sometimes, for example, over here also religious leaders and so forth. And they developed they worked on the theory of change, which was vital in implementing the UpSites peer support. But unfortunately, there's a paper published on theory of change in UpSites, so actually a couple of papers. So, but it's not part of this presentation over here. So, and then were peer support workers including in publications and outputs? Yes. There were some service user researchers at study sites who actively contribute to publications, and peer support workers are, for example, in the main publication I will be presenting later on, which were the main results of the RCT. There were, I didn't count them, but I would say 1, 2, 3 peer support workers from each site who were co-authors and who also actively contributed to the publication. So it wasn't only honorary co-authorships. Okay, Asanta Sana. I think I heard this. What does this mean again? You know, I don't.
Yeah,
I think I heard this, but
thank you very much.
all
Yeah.
right, all right. Sorry, it's been a long time that I've been in Tanzania. I should go. I should go again soon. Okay, so I think we'll close the Q&A session for this presentation. And was there a hand raised,
Yes,
Claudia?
Claudia.
Yeah, Claudia.
I I did have my hand raised, but I don't know if there is time. There's just a question on the live chat that was posed about challenges and what challenges did you come across and conquer? So I see that's in the live chat. So I don't know, in the Q&A section, sorry. I don't know if you have just a minute to maybe cover that before you proceed.
Yeah, maybe that's a question then really for Donat by Filani
Yeah.
Kenyabo. What interesting challenges did you come across and conquer? I
Well,
suppose it refers to the implementation of peer support.
yeah,
And,
well, I wonder Ben, whether this maybe can be addressed after your presentation, because it depends on challenge at which stage, because yeah, there are
right.
challenges during the implementation, for example, during COVID-19,
Okay.
that as itself, it is
Okay.
something.
I mean, there were hundreds of challenges,
Exactly,
and
yeah.
but maybe Filani, you could maybe be a bit more specific in at what are you talking about research? Are you talking about implementation? Are you talking about uh, uh, peer support worker teams and so forth? I mean, there were hundreds of challenges, of course, and so maybe then we'll answer it in the end. Implementation. Okay. Yeah. Um, I can say a bit. Um, we we before starting the implementation, we did a focus. No, Galia, you will be talking about this in your presentation, won't you? But implementation challenges, right?
Some of
Or
them, yes.
shall we let you talk first, and
Sure.
then yeah, I think part of the answer to this question will be in your presentation, and if not, we go
Yeah,
back to this
although
later.
I agree with you, there are so many challenges.
Yeah, I
There'll
could
be a
go
snippet,
on for hours now, but
but
yeah.
happy to
But let's move on with the
okay,
presentations. If
all
that's okay
right.
with Filani, we didn't forget about your question, and we'll get back to it later. All right. So next presentation is by Galia Moran, Bershaba, who will be talking about multicultural perspectives and experiences of peer support workers providing peer support in mental health services, qualitative findings from the Upside study.
Yes, thank you, Bernd. Can people see my slides?
Yes.
Okay, so I'm really happy to continue this conversation, this talk about upsides on a part of the study. And maybe this is just to take a step back and say, we're presenting here 4 studies out of a huge project that went over 5.5 years with a lot of sub-studies, and this is really just a small part of it. And so we are happy to continue this conversation also afterwards, and to connect and to refer you to other studies. But maybe just to connect to the question about co-production or collaboration. What's very special about this study is from the start, it's planned, and this, by the way, you can look at a study from 2020, which gives the whole the protocol of the study of these series of studies, is really built in a way that is interweaved all the times in connection with local stakeholders, with these advisory boards that are placed in each site, and that there's all the time a kind of like implementation science feedback loop going on. So for example, when Candelaria presented, I don't know if you've noticed, but when she presented about the building the structure of the manual, she was really showing how they went from current state analysis to checking this current state and a very initial manual with local stakeholders and peer support workers. And then after doing that, developing some kind of training, but this training wasn't enough, going back to local sites and testing this in a pilot, and only after testing this in a pilot, doing the modification. So it's a kind of iterative, very thorough process that is on one hand, well, taking concepts and knowledge from academia, but all the time tying it back to the people you're working with and building it in collaboration. And I think that's maybe another reason why we didn't feel such a big, issues around power hierarchies. Of course, there's issues about interactions between people and, and people not maybe delivering things in time. But it was more like personal level than power hierarchy issues, etc., because I think it was so well built with these implementation science principles and a huge sensitivity to recovery and to the respect to the knowledge that people with lived experience give, and we want to bring that forward to the front, structurally built within this project. So taking this presentation forward after Candelaria and Donat's presentation about that current state of analysis before of peer support, I'm going to sort of fast forward us to the actually very end of this 5.5-year project, after peer support workers went in each country, went through the training in their own local native languages and implemented the UpSides training in their own adapted organizational cultural context, but all doing UpSides at the same time with the same principles and those modules that Candelaria was talking about: recovery, communication skills, tree of life, etc., etc. And here we wanted to learn from the peer support workers themselves in this specific study about what was their experience of training and implementing this actually innovative international manual that we've developed. And this is a paper that's been published in the last fall, and you can see here the people that were involved in it. Some are also people with lived experience in this paper. Just very briefly, I'm going to say what we did and jump right into snippets of quotes, which I think are most interesting. We had 38 peer support workers that were interviewed in focus groups across the different sites, 2 in Germany, in Uganda, in Tanzania, Israel, and India. And we recorded and transcribed those focus group narratives and analyzed them using the qualitative methodology, thematic analysis, for people who might know the Brown and Clark method. We used MaxQDA software, which is software which allows to do a mixed methods, qualitative and quantitative analysis, which was largely used across the project. And I also mentioned here that we did cross-validation with local research members in each site, because we were a group of German and Israeli for this specific study that were doing the analysis, and but the translation was with bilingual people in each local site. And after we had the transcripts, we also went back to check if there was some jargon or things we didn't understand from the sites that were not that we did not come from either Germany or Israel. So to make sure that we're not missing out things or not understanding specific things. And in general, it was very interesting to see that cross-sites peer support workers related to similar experiences. There's some distinct themes, but there's big, broad areas that are pretty similar. Peer support workers were talking about their own recovery experiences as a result of being involved in the training and implementation of UpSides, developing also vocational skills, occupational wise as well, interpersonal skills as well, following the training and the implementation. There was a lot of reference to their own work role and their relations within mental health systems. I do not go very deeply into this, but because people before somebody asked about challenges, this is one of the big challenges across sites, the issue of the development of a clear work role and integration with in mental health services. I will say a little bit about that, but there's more written in other papers, in this paper and in other papers as well. And surprisingly, because this was not necessarily part of the UpSides protocol, peer support workers across the sites were striving to influence broader circles, which was very inspiring to learn. So I'm going to just give snippets of quotes from each of these of these categories now, okay? Try to speak as close as I can from the voice of the peer support workers. So for one thing, the peer support workers were talking about how they felt enhancement in both illness management aspects of their own mental health condition and empowerment. A peer support worker from Germany here says, as a peer support worker, I am reminded of my story and think, oh, wow, I've come a long way. He will do it too. She will do it too. These are the service users, yeah? And then I can be a bit proud of myself, how far I have come. Or a peer support worker from Uganda says, Upsides also helped me work on my own recovery, knowing that I was a role model. So definitely knew that if I stop my medication or do something that could trigger a relapse, then my peers, that is service users, would be discouraged. And this is a very classic example of the core of being a peer support worker and how being a role model also helps one better take care of their own mental health condition. It's a very nice quote here. And then a peer support worker from Tanzania who talks about tangible supports. It has become easy now for me to access services. For example, if I face a problem, I can contact Madame, this is an occupational therapist, and she gives me support easily because access there wasn't very easy for this person. So this is about recovery. Now I'll give some snippets about how peer support workers through the training and the implementation are talking about developing interpersonal skills as part of this vocation. For example, a peer support worker from Tanzania says, I was so scared to speak in front of other people and I couldn't establish a relationship, but the Upsides project has changed me. I have met people face to face and I have been able to talk to them. It has changed me and I can change my career to become an educator. Or another peer support worker from Israel says, Upsides gave some sort of structure of how to disclose myself in a way I really wanted to and didn't. Something in the training helped me formulate this sort of identity of being a worker with knowledge from experience. So we see here that this peer support worker talks about a kind of professional identity or vocational identity of a peer support worker and how to bring out one's lived experience when they talk about self-disclose myself. And a peer support worker from Uganda says, I also got some skills that have helped me in my personal relationship. For example, training on conflict resolution has been very helpful. I also got skills in speaking, basically being able to talk to someone and listen, and also self-disclosure to build rapport. These are very important basic interpersonal skills, which seems all peer support workers seem to have gained a lot from. And here a little bit about the challenges, as I spoke before. Here are some examples. So a peer support worker from Tanzania says, when the peer support worker meets with the service user for the first time to provide peer support services and to share their mental health challenges, it is a little difficult for the service user to trust you. So it's hard to gain credibility as a peer support worker, right? Or a peer support worker from India says, everyone thinks that we, peer support workers, are also there to take medicines. If we are in a dress code, they will treat us normally. They will then understand our value. So they're asking for some dress code so that they are noted as a provider and not as a service user. And a peer support worker from Germany says, from Ulm, I think it definitely does good to introduce peer support in ward management meetings, at the nursing service management, at presentation events, so that it is simply anchored in the minds of the colleagues and in their awareness. So as you see, these challenges are both with service users and with the staff and system to acknowledge and really value what peer support workers can give. And the fourth theme, which involves striving to influence broader circles, I bring a few quotes and I invite you to read more in the paper. So this peer support worker from Tanzania says, Upsides helped me get confidence and come out on social medias and share videos about mental health, what helped me, and how I am using my medication. There are some who reached out and I spoke to them. It is not shameful to have mental illness that you cannot do anything in the community. You need to pull the topic of mental illness out of the taboo corner. And another peer support worker from Israel says, awareness can only come by carrying the message. We talked about it and carried some sort of message. We are copers rather than being mentally ill. And we bring knowledge from experience, and we came to open up something. And while we had these across the board themes, of course, there were some differences, which I try in a nutshell to mention here, between the low middle income countries and high income countries. So in low and middle income countries, what was very prominent that in addition to the sort of more psychological or subjective gains, peer support workers were really gaining instrumental benefits. For example, gaining better access to care, to medication. Their employability is enhanced. Some people started working after a long time of being unemployed and really gaining a financial standing. In addition, in these countries, usually the peer support workers were oriented to the community. They were interacting with, in addition to the service users, they were also interacting with family members, with police, with army, doing all kinds of psychoeducative activities and trying to help better address service users. And again, including anti-stigma activities. In high-income countries, peer support workers were often discussing issues of self-disclosure and peer identity in the development of this role vocation. And they also often, their activity was within the mental health systems, where there they were trying to raise awareness about peer support worker roles and stigma. So it was sort of more within the institutions and the services that they were acting as opposed to the low middle income countries. And I think it does speak to the cultures, the differences between individualistic cultures and collectivist cultures, as well as the very low resources in the low middle income countries where peer support workers were really functioning as community bridgers and really helping out in a lot of important aspects to families and other stakeholders in supporting service users. So in conclusion, I was very inspired from being involved and feel very privileged in this project. I think it really demonstrated that peer support work and recovery principles are universally embraced. And I think this is the thing I forgot to say, that I think very quickly in our project, people felt, coming from different cultures and different places, felt like we are like-minded because we all aligned on the principles of recovery and peer support, irrespective of where we went for. And I think that was a very strong glue, so to speak, that helped also overcome challenges. And I think what we see from this project is how, in being engaged in this study, how just being engaged as a peer support worker benefits your own personal recovery, which we already know, but also we see that it also can drive societal change and help global mental health across the board. And tying into what Donut said before, the task shifting, the treatment gap, the need for more workforce, it actually comes as a valuable promise in that sense, both to low middle income countries and high income countries, which are also struggling with a lot of mental health issues nowadays. So I feel like I've taken too much time, And I will just say that, of course, I can send the presentation to whoever is interested, and finished with this picture that kind of shows parts of the ways of the journey we went through and the people that were involved, and to thank again for this lovely opportunity. Thank you.
Thank you, Galia. It was a very good presentation, but we're also running a bit short of time.
Yes.
And in order for my presentation, so I can still squeeze it in a bit, I suggest we take the questions in the very end, and I'll try to move on now. So I'll share my screen now, Zach, is that correct?
You are more than welcome to.
Oh, Galia, you have to
How do
stop your screen sharing.
Yeah, I'm trying to get to it. Is it not allowing me? Oh, there. Okay.
Is this working?
Yes, we can see your screen perfectly.
All right, so thanks for all who remained in this webinar, for listening to us for such a long time. I will now present findings of the UPSIDES RCT, where we looked at the effectiveness of our peer support intervention, of which you have heard about already so much. So I will, here's the outline of my presentation. I will give you some background, and then, well, it's the usual outline. I will talk about the methods, results, and some ideas for the discussion. There's accumulating evidence that peer support is effective. A number of meta-analyses and individual RCTs have established effectiveness. It helps to reduce. They're as effective as mental health professionals, peer support workers, and peer support workers might do better than professionals at improving, quote, softer, unquote, recovery-related outcomes, for example, social inclusion, empowerment, hope, self-esteem, and self-efficacy. There are significant gaps in the evidence on peer support, especially in low and middle income countries and in non-Anglophone high income countries. And there's a need for large scale international trials to strengthen the evidence base. So this is what we did then. We tested the effectiveness of a manualized peer support intervention for people with severe mental health conditions in a range of high, middle, and low income countries. And the hypotheses were that UPSIDES peer support would improve social inclusion, which was the primary outcome, and secondary outcomes were empowerment, hope, recovery, and health and social functionings. Yeah, this was the UPSIDES study. You know about this already. We recruited in Butabika, Ifakara, Gujarat, India, Beersheba, Israel, and Hamburg and Ulm in Germany. The intervention was delivered in a one-to-one format at 5 study sites, and in Israel, this was one of the challenges. This was one of my big challenges. Israel was a bit special. They wanted to have a small group format called Hefruta, which would fit better the mental health system there. There's also a paper published about this. And yeah, it was one of my bigger challenges. So there was a mix of formats. It has been the intervention has been described, published. Candelaria talked about this before. Donat has talked about it. Here's some of the papers. It was piloted, and we have the training manual workbook. It is online, available for everyone. And we also have the implementation manual. This was led by Juliet Naku and from Butabik, and Grace Ryan from London, and a range with a lot of other people. Can also be downloaded at at our website. So this was a pragmatic parallel group, multi-center randomized controlled trial with 4 measurement points. Here you can see the inclusion criteria. We're looking at severely impaired people with a threshold assessment grid measuring impairment and a long illness duration. And here are the outcomes. There's the social inclusion scale, which we have adapted for use in our study. It has been translated as all other measures and lots of other materials. This was also a challenge I underestimated. Translation was massive, so we had to do a lot to this end. Then there was the empowerment scale, hope scale, stages of recovery and health of the nation's outcome scale. And we used hierarchical linear models, and the effect was the difference in slope, that is, the monthly change rate on the given outcome due to allocation to intervention or control group. We have published, it has been pre-registered. We published the protocols. This was for the overall project. This was the protocol specifically for this RCT. And now to the results. We had 600 plus calculated as the necessary sample size. We over-recruited even a bit, mainly due to, I must say, sites in East Africa, Bouteflika and Dar es Salaam, who were really very good at recruiting, but also other sites met their targets, and there was another challenge. Oh my God, I'm listing challenges because right after the start of recruitment, COVID hit in, and it really well, that was horrible. And yeah, but we managed. We went through, and I could go on about mitigation measures and so forth, but I will. I think people will also want to hear the results, maybe. On average, participants were in their late 30s. More than half were female, most were single, and had completed secondary education. Many participants were unemployed, living alone or with their parents. Diagnosis, this was self-diagnosis. We did not formally like SCID or something to assess diagnosis. It was a mix of depression, psychosis, and others. And long illness duration, approximately 15 years, and key baseline characteristics substantially varied by study site. This is not shown here, but if you, this is all part of the publication if you want to read more details. Participants allocated to the intervention group, 90% received at least one session of peer support over the course of the intervention period, which lasted approximately 4 months. And participants received 7 sessions on average, which often lasted 30 minutes or more. And the vast majority of sessions were held in a 1-to-1 individual format, except for Israel. And some sessions were held in a group format with an average of 5 participants. This was the Hefruta. And so here's the effect. This is a bit of a complicated slide. Afterwards, I have an easier version. This is just to say that intention to treat analysis found significant effects of 2 of the 3 social inclusion subscales: social isolation and social acceptance. You can see that here in the and does this work when I wait a second, when I cross this here? This is this and this. This is the intention to treat, right? And also intention to treat. Intention to treat is everyone who was allocated to the peer support group was entered analysis, even those who did not receive any session. So and then there's the per protocol analysis, which from methodological point of view is a bit less strict, but to me it makes more sense because this includes only people who have at least received 3 sessions of peer support, which we would say is like the minimum dose for to see any effect. And there you could see that the here that's the primary outcome, social inclusion total. There was an effect, and also the other effects were uh, uh, on the social inclusion subscales and on empowerment and hope. They increased. All right. Here's the easier version of this complicated slide. All right, it still has my, what can I do this on my screen? These my doodles remain now. I don't know how to get rid of them. All right, I'll move on. I don't know if it's the same for the audience. Is it?
Yes, it is,
We see them.
unfortunately.
How can I get rid of the doodles? That's a very stupid question.
Try
All right.
Control Z, Control Z.
Oh.
It's okay. It's
I
No,
guess
I won't. I won't. I won't do anything that might kill my whole presentation.
that's true. That's okay. We can
All right,
understand
I'll just
you.
move on. That's
it's
very.
nice. It's
I never
it's
used this stuff
creative.
before, and now I'm doing that. All right, social. Yeah, this is again the effects. All right, for the. No, that looks very horrible. All right, for the discussion. Um, Assets peer support, improve social inclusion, hope, and empowerment in a large-scale, multinational, randomized, controlled trial. There were some limitations. There was the COVID-19 pandemic, which required a number of contingency measures. For example, delay of the we decided that we will not go into online because we think peer support has to be a personal intervention. So that's one of the so we had to delay. People were told you're getting peer support next week, but then it couldn't happen because people were not allowed to leave the house. We had the mix of formats, which is a bit of a methodological challenge. Blinding was limited to researchers only, carrying out data checks and data analysis, but nobody else was blinded. And in the absence of a control intervention, non-specific factors could have influenced the results in favor of the intervention arm. Conclusion and outlook. We believe that results imply that peer support, upsides peer support can serve as an effective component of recovery-oriented mental health care in diverse settings. We have to balance evaluation and capacity building. There might be further scale out to scale up to other populations and scale out to other contexts. We have next planned analysis. We have a process evaluation focusing on mediators and moderators of effect. Actually, part of this has already been done and will be published soon, as will be the cost effectiveness analysis. The paper has been submitted. I'm planning soon for an investigation of short and long-term effects because this paper was only about the midterm effects, and we want to investigate the impact on peer support workers, and we will inform mental health policy implementation practice, ensuring that the perspectives and unique contributions of people with lived experience are considered to moving mental health systems towards a recovery and right-based orientation. So this is the paper. If you want to read it, it's been published in the British Journal of Psychiatry last year. This is the mediation analysis I was mentioning. It's been accepted by Ramona Hildensberger and colleagues. And here's some acknowledgements. And thank you very much for your attention, and thank you to Abels for hosting us for this webinar. So that's my presentation. So I think we now still have some time, 22. So we still have 8 minutes for questions and comments to all presenters. Raise your hands, use the chat. I'll check the chat. Amen. yeah, this was Charlene. This makes a strong case for the value of peer support workers and should be integrated with the mental health system as a professional mental health workforce. Love the quotes from peer support workers, very powerful. Thank you. That was, I think, mostly for the qualitative presentations. The first three, actually, I didn't have any quotes by peer support workers in my presentations.
There is some question in the chat if it's adaptable to every country. Yeah, we made the manuals with the aim in mind that it would be adaptable to everywhere. So, yeah, so the training manual, but also the implementation manual is a really great manual that gives you the topics to think about for your country and for your location. But it's not saying you have to do it this way, just yeah, guiding you in that.
Exactly. So what we, just to mention, I mean, that's a bit of a commercial break, but just to mention that we also are moving a bit towards a resource center for upside peer support. We would be happy to be involved in adaptations of the training and implementation of the training. We can provide peer support worker training, organizational readiness training, as Candelaria and colleagues just did in Sweden. So of course we did not put a copyright on it. I mean, there is a copyright on it, but it's open source. Everybody can use the training, but we would be very happy to be involved and for it to be acknowledged and for it to be called Upsides Peer Support Training. I think it's important for us over here to be involved and at least consult a bit. All right. There was this one question I overlooked.
There is a question about policy
Yeah.
makers, and I think, should I answer that, or would
Yeah,
you like
please
to?
go ahead, Galia. Yeah.
So yes, indeed, in this, policy makers were involved, as Candelaria has just written, and throughout the stages, very much from the beginning. And I think this speaks to why the project succeeded in the different sites. For example, in Israel, because we interviewed policymakers from the start about this, talking about readiness, about their needs, about the challenges. Then when Upsides was already formed, it was embraced by the mental health ministry, and there's a training for it now. And the first training was funded by Upsides, but then the Ministry of Health would embrace it and take it forward into its continuing education school. And I think it was in different versions, but similar processes in the other sites to as much as.
Yeah, I think, for example, for Germany, it was difficult to involve policymakers, and it's difficult to get funding beyond the project. It's been a struggle. It still is a struggle, and but we're hoping to be better. There's still a lot of skepticism, also at my institution, for example, about peer support. It wasn't very easy to. If you look at when we had the situation analysis, I think readiness to implement was higher in most other sites. I think we were pretty skeptical bunch of people over here, and yeah.
Well, you had competition with X-In and
Yeah.
trials.
No, it wasn't because of that. It wasn't because
No?
of that. No, it was just I think there's some. It's still difficult. People are not. I mean, it's like in a bubble sometimes. It's like we people think recovery and it's very
Yeah,
important and
right,
everybody should, but there's other people who
right,
see things very differently
right.
who are also there and who need to be convinced, and sometimes it's very
Yes, we have that.
sometimes it's a bit tiring. I found it sometimes a bit tiring. All right. Other questions. Preparatory one. Policymakers. Policy. Yeah. What you say about policy? What we presented this at a GACD meeting. What policy always wants is cost effectiveness analysis. What's the return on investment? This will be published soon, and we hope that then there will be a reignited, I hope that's the right word, interest by policymakers to implement and see that it's not only helping and effective, but it's also cost effective. and policymakers were involved. Oh yeah, you wrote in the theory of change. All right. Do we have
We have
FAQ?
some Q&A,
Oh,
some
there's a lot of
questions.
questions. All right. You want to read them, Zach, or should I read them, or
Oh, you're more than welcome.
whatever? What are the main lessons for the research and implementation? Is there something you wish you did differently?
Always.
I would do it the same again, exactly the same. No, yeah, I don't. Anybody who wants to answer, or I have to think about it. I have to think about what to say. I think I would not really go into another RCT. I think I would really go on the implementation side if I did it again, because there've been so many RCTs now. I think the evidence is established, and I think it should really be better than we should more look into context, implementability, spread, what are the conditions. We did that, but
Yeah.
and we had some success in moving beyond in implementing beyond the study sites, but I think it could be better. So maybe that's something I
Yeah,
wish.
I disagree. I
You
think,
disagree?
yes, I think it was excellent. And I think what I learned is how important it is to work systematically, stage-based, and slow. Maybe it's because I'm coming from a country now, definitely, but always in chaos and always things are done very quickly. And this was
Mm.
methodical and thorough and working together. And I think I learned about piloting, how important it is to pilot and pilot again and check and get feedback. And I think what we didn't do well is we didn't think about forward. Why are we not, how can we set up things for the future to continue the
Yeah, that's what I meant. That's
sustainability
what I meant. That's what I meant.
in that
Yeah, that's
sense?
what I meant.
Hmm.
Yeah, I
The
think there were some
sustainability.
because you were also there's there was COVID and it really stressed out
That was,
everyone so
yes,
badly. And then it also for myself, I can say you were only trying to manage the project
right,
for it not to come to complete end.
right.
And everybody was having a bad mood and everybody was stressed. And
That's true. COVID
so,
was a
but
huge challenge, huge
maybe
challenge.
thinking more, if I would do it again, I would try already early on to think more into the future.
Yeah,
And it's not, I'm not saying that we didn't do that at all, but I think sometimes I regret this a bit.
yeah.
Does the training
Indeed.
consider
Yeah.
responsiveness in times of humanitarian emergency, armed conflicts, and disaster? I would say no. I think, and I would say that, as I said, I think it's an excellent intervention, and I think it can be adapted to uh, these situations or more challenging context. But I think then it's more a question to you, Candelaria. But I think then we would have to maybe rearrange modules and add modules. And what do you
Yeah,
think?
but actually, it was a topic if there could be modules for
Hmm.
humanitarian emergencies, exactly as Gaia said, because of yeah tumults in Israel. But we decided that would have to be an extra module and not in our core modules, and we didn't develop it during the upsides project time. So we've been thinking about it, but we, as you said, everything got a little bit rushed and tense with COVID, so we didn't finish those.
Sometimes I do get requests now. For example, just recently I got one. Can we, how about adapting it for prison population? I think it's possible, but it's not like as it stands, it can be used for anything. It needs some adaptation, but I think the core idea, as we did it in the upside study, I think that's very global and can be used for a lot of situations and populations.
I
For
think
a
so.
country with a lot of stigma and where no peer support has ever been implemented, would you promote peer-to-peer support to gain yeah, I would definitely say yes. And
Um,
but who wants if anybody I would know from some
usually,
experience from upside. Yeah, go ahead, Calaria. Go ahead.
okay, usually in nearly in every country you have some kind of self-help organizations. So peer support is not something that's coming from the academic level, it's coming from bottom up. And for sure, in your country, there will be some organizations or some initiatives around self-help and peer-to-peer support on an informal level. And I think to invite people from there to talk about their work and about recovery. Also, in formal settings can be really, really helpful to introduce or to make people curious about peer support and wanting to know more. And also seeing how, yeah, how impressive it can be to talk with someone with lived experience and who can explain these critical situations, but in a time of recovery where you can really express yourself well. So I think that's a good bridge for the first contact. Yeah.
And I know from sites and upsides with a lot of stigma that sometimes it was because very often the meetings were held in public spaces, like parks or something. But sometimes it was difficult for example, I know from some high stigma situations where peer support workers would have to say they're someone else, they're coming to visit, and not say we're here for a person with mental health problems. But still, I think there's ways, and I think peer support is such a great intervention. Of course, ours is a very good intervention, but also other peer support programs are really very good. And I think it should there should I think there's ways to also implement it in high stigma environments. That was a question by Sasha Haj Asaf. I hope we answered all the questions now. I can see we're already 4 minutes over time. Oh, there's one more message. Thanks, Galia. Thank you for your answers. So I don't hear or see the audience. So I suppose there are no more questions. There's still 18 people in the audience. So F&A, wait a second, there's more. Is there more? No, I think that's it. I hope we answered all the questions. If not, please tell us now if we didn't. And
Free to
you can
contact us
contact
as well.
us. I think on the presentations there was contact information, or you could just maybe, if that's okay, ask Arvis Mental Health, or you can email us. You can for any questions that we didn't answer right. So I would like to thank again Charlene Sunkel, Claudia Sartor, and Zag for having us for this opportunity. And I would like to thank all the presenters, Galia, Candelaria, and Donat. And then I would close the session and wishing all of you good evening or wherever you are, a good time of the day.